You hear a conversation between a dentist and patient called Mr. Roberts.
Good afternoon, Mr. Roberts. How can I help you today?
Good afternoon, doctor. I've been having a lot of pain in my lower right molar.
I'm sorry to hear that. How long have you been experiencing this pain?
It's been about a week now, and the pain has progressively worsened. I've noticed that it intensifies significantly whenever I chew or consume something cold. It starts as a dull ache and quickly escalates to sharp, throbbing pain that's almost unbearable. Even simple activities like eating or drinking have become challenging because of the discomfort.
Have you noticed any swelling or other symptoms?
Yes, there's noticeable swelling around the gum area, and it feels quite tender to the touch. The swelling has been persistent, making the affected area sensitive and sore. It's become uncomfortable to brush my teeth or even touch the gum with my tongue as it exacerbates the pain. The tenderness and inflammation are really concerning, and I'm worried it might indicate a more serious issue.
Have you taken any medication to relieve the pain?
I've been taking over-the-counter painkillers, but they only provide temporary relief. Initially, they dull the pain for a few hours, but the discomfort returns once the medication wears off. Despite following the recommended dosage, the pain persists and sometimes even seems to intensify. This short-lived relief is frustrating because it doesn't allow me to manage my daily activities effectively, and I'm concerned that the underlying issue isn't being addressed.
I see. Do you have any medical conditions or allergies I should be aware of?
I'm diabetic, but my condition is well controlled through medication and a carefully managed diet. I regularly monitor my blood sugar levels, and they have been stable for quite some time now. Additionally, I don't have any known allergies, so there are no concerns about adverse reactions to medications or treatments from that perspective.
All right, let's take a look. We'll do an examination and possibly an X-ray to see what's causing the problem. Does that sound good?
Yes, that sounds fine. Thank you.
You hear a conversation between a patient and a physiotherapist.
Hello, Ms. Thompson. I am Dr. Green. How are you today?
Hi, Dr. Green. I'm managing all right overall, but I've been experiencing significant back pain recently. It's been quite persistent and is really starting to interfere with my daily activities. The discomfort has been intensifying, and it's becoming harder to find relief or a position that alleviates the pain. I'm concerned about this ongoing issue and would appreciate your advice on how to address it.
I'm sorry to hear that you're experiencing this. Could you provide more details about the pain? Specifically, I'd like to know how you would describe it, whether it's sharp, dull, aching, or throbbing. Additionally, please let me know the exact location of the pain. For instance, is it concentrated in a particular area of your back, or does it radiate to other parts of your body? Understanding these details will help us determine the best approach to manage and treat your discomfort.
It's a sharp, piercing pain in my lower back that becomes particularly intense when I bend over or try to lift anything. The pain often feels like it's stabbing or shooting through the lower part of my back, and it can be quite debilitating. Simple movements, such as bending to tie my shoes or lifting a grocery bag, seem to aggravate it further. This sharp pain makes it difficult for me to perform everyday tasks and impacts my overall comfort and mobility.
How long have you been experiencing this pain?
It's been about 3 weeks now.
Have you had any recent injuries or changes in activity?
I haven't experienced any recent injuries or accidents that might explain the pain. However, I did recently start a new job that requires me to sit for extended periods throughout the day. This new work environment involves long hours at a desk, which means I'm spending much more time sitting than I used to. I'm wondering if the change in my daily routine and the prolonged sitting could be contributing to the discomfort in my lower back.
Oh, I see. Have you tried any treatments or exercises to relieve the pain?
I've attempted a few measures to alleviate the pain, such as doing various stretches that target the lower back and using heat packs to relax the muscles and improve circulation. Unfortunately, these methods haven't provided much relief. The stretches seem to offer only temporary comfort, and the heat packs, while soothing for a short period, don't seem to address the underlying issue. Despite my efforts, the pain persists and continues to affect my daily activities.
All right, let's assess your range of motion and strength. We'll also go over some exercises that might help. Does that work for you?
Yes, that would be great. Thank you, Dr. Green.
You hear two trainee doctors doing an activity at a staff training day. Now read the question.
So, what did the trainer say we have to do?
Well, we've got to look through these case notes, 10 sets in total, and decide which of the patients should be referred to the consultant as a matter of urgency and which can wait.
Oh, right. And did I hear him say there's a limited number you can refer?
Not exactly. He said that we should put them in rank order according to the severity of the symptoms and other factors evident from the case notes. Once we've agreed on our list, we have to go and compare with another pair of trainees.
Okay, let's get started then.
Question 26. You hear a radiographer talking to a patient about her MRI scan. Now read the question.
Come in. Mrs. Brown, isn't it? My name's Ted, and I'm going to be doing your MRI scan today. Now, can you get up on the table for me?
You know, I'm really claustrophobic.
Well, this is a new piece of equipment. The diameter is much larger, so it should make it a little more comfortable for you. You'll also have this call bell, so if you need me at any point during the test, you squeeze that, okay?
Okay.
Now, your scan's only going to take about 15 minutes. Are you okay with that?
I am.
Okay, let's get started then.
Question 27. You hear two nurses discussing an article in a nursing journal. Now read the question.
Did you see the article about research on strokes and sight problems in the latest nursing magazine?
Yes, I found it interesting that there's quite such a high degree of visual impairment after a stroke.
Yeah, but I think I could have told them that without an expensive research study.
Well, you need evidence to get progress in how people are treated. And now there'll be a push for all stroke patients to have eye assessments as a matter of course.
It certainly makes a pretty solid case for that, especially as there's plenty that can be done to help people if early screening diagnoses an issue.
Absolutely.
I was just sorry the article didn't provide more detail about the type of sight problems that are most common after a stroke.
Well, there's a reference to where the whole study's been published, so you could always find out there.
Question 28. You hear two hospital managers talking about a time management course for staff. Now read the question.
The uptake for the course in time management for staff has been disappointing, hasn't it?
It has, but I'm not exactly sure why, because everyone seems to know about it. And we asked for it to be changed from a 4-hour session to 2 2-hour slots to make it easier for nurses to be released from their wards. But apparently that wasn't possible because it has to be done a certain way.
Yeah, I'm not convinced that was the problem anyway. I think once staff become aware of what it's aiming to do and how it fits together with other initiatives, there might be more interest.
Yeah, there certainly is a need, even if the staff themselves don't actually realise it at present.
Question 29. You hear an optometrist reporting on some research he's been doing. Now read the question.
I specialise in dealing with fungal eye infections. At present, treatment involves giving eye drops every hour for at least 2 weeks. I wanted to improve this process by designing a system capable of releasing antifungal drugs onto the eye over an extended period. Contact lenses are perfect for this, as their hydrogel structure has the ability to uptake and release drugs, and their placement on the eye ensures the drug gets released directly to the cornea. In order to make a contact lens provide drugs over a sustained period, I've modified the lens. I've also used nanoparticles for packaging the drugs. So, I've managed to create a system capable of delivering an antifungal drug, called nanomycin, for up to 4 hours. I now hope to increase this, and use this system with other drugs.
Question 30. You hear a consultant talking to a trainee about a patient's eye condition. Now read the question.
Have we got Mrs. Kent's notes?
Yes, they're here. She's coming in today for possible laser surgery for her retinopathy, isn't she?
Well, depending on results. And from the look of these pictures we took last time, there's been a slow improvement. So we'll talk to her, and perhaps hold off for the time being, unless her condition's worsened, because it can in some cases.
So what's the cause?
Well, we know a leak of fluid behind the retina causes the distorted vision which sufferers get, but not why that occurs. There may be a link with stress, and also steroid use, but the jury's still out, I'm afraid.
You hear a presentation by a consultant cardiologist called Dr. Pamela Skelton, who's talking about a research trial called SPRINT, which investigated the effects of setting lower blood pressure targets. You now have 90 seconds to read questions.
Hello, I'm Dr. Pamela Skelton, consultant cardiologist at this hospital, and I'm talking about the recent SPRINT study into the effects of setting lower blood pressure targets, which in turn affects the advice and medication which patients are given. I'm going to describe the patients who were selected, how the trial was conducted, and the implications of its results for us all as health professionals. First, the trial itself. It involved over 9,000 hypertensive participants, aged 50 plus, most of whom were on blood pressure medication. They were randomly assigned to one of two groups, one with a goal of less than 120 millimeters systolic BP, the other with a goal of less than 140 millimeters, the traditional standard. The intention was to follow these patients for 5 years, factoring in the usual dropout rate. As it turned out, however, the trial was stopped after just 3 years, thanks to an all-cause mortality reduction of nearly 30% for the 120 group, which was definitive and shocking, but wonderful. As I mentioned, the participants were over 50s, and it goes without saying that as people age, they develop more diseases and health problems as a matter of course. But there was a specific group of over 75s who did just as well as younger patients. Before the trial, some medics referred to the natural stiffening of the arteries with aging, suggesting that 120 was too low a target for the over 75s, risking an increase of dizzy spells, which would affect general well-being. But this concern turned out to be unfounded. Others thought there would be a failure to take the number of tablets needed to reach a BP of 120, especially among older participants. Again, this wasn't an issue. The average needed was just 3 per day. The over 75s, already on various drugs, didn't object to extra medication. Participants from this age group who didn't finish the trial were taken out because some conditions, which were already present, worsened. For example, in some cases, obesity levels rose too high. To manage their blood pressure, participants were given standard drugs, nothing experimental, just drugs that are readily available and low cost. Another key factor was that blood pressure was measured in a very specific way. Rather than give patients an arm cuff for at-home 24-hour ambulatory monitoring, an automated machine was used at the hospital. This took 3 separate readings and averaged them. Also, readings were taken while staff were out of the room to avoid what's called white coat syndrome in patients. Now, some of you may be familiar with the ACCORD study into blood pressure levels several years ago, which in some respects was similar to SPRINT. There are some differences, though. For example, ACCORD was about half the size of SPRINT, and unlike SPRINT, the ACCORD study allowed diabetic patients to take part. Despite this, in general, the ACCORD participants were rather lower risk than those in the SPRINT trial, probably because of the slightly lower average age. The ACCORD trial didn't show a statistically significant benefit for overall cardiovascular outcomes, but there was a clear 40% reduction in strokes, even though that was a secondary outcome. So to summarise, the SPRINT trial seems to support 120 as a recommended blood pressure target. This is doubtless a landmark study, and importantly, one which was sponsored by government rather than by the interests of pharmaceutical corporations. I recommend a note of caution, though, as SPRINT does contradict previous findings. The Cochrane view, in 2011 for example, said that lowering to under 140 didn't produce a change in the risk of death overall. However, we must bear in mind that Cochrane was looking retrospectively at trials which weren't actually focused on the same particular issue. So it's worth doing a full and systematic evaluation to see where the SPRINT trial fits in with what we already know. It's interesting that a few GPs have already been working with older patients to hit lower blood pressure goals, and the new data will doubtless encourage greater take-up of this more interventionist line of attack. But the SPRINT results don't mean that everyone with hypertension should be dropping to under 120. Plus, to achieve those lower levels, it's unlikely that lifestyle changes alone would be enough. It could well require several antihypertensive drugs as well. There remain some unanswered questions, of course. For example, whether other groups, like those with a lower heart attack risk, need to keep their blood pressure that low. So, while SPRINT can help guide doctors' decisions about some patients, it doesn't mean that a new universal standard for blood pressure is in order. Instead, it's a good reason for everyone to discuss with their doctor their own ideal and particular target.